prevention is really where we should be spending more of our efforts in the years ahead to change not just child health, but the future of health for the NHS.
Children who are at higher risk, so children with immunodeficiencies or parents of premature babies, actually could be the champions of vaccines because it's so much more important for their children that everybody around them is vaccinated. Hello and welcome. So I'm very excited to introduce our most eminent guest we've had on our podcast so far, Professor Sir Andrew Pollard, who is a paediatrician in infectious disease and immunology and director of the Oxford Vaccine Group and head of the Joint Committee on Vaccination and Immunisation. So good morning.
Good morning. Thank you very much for having me on the podcast. I'm not sure about the eminence, but very kind of you to introduce me that way.
And as usual, I have Christo, who is our PhD student and trainee in immunology and infectious disease, to keep me on the straight and narrow. Good morning, Christo.
Morning, Emma.
So we had a whole list of questions and things we wanted to ask you. But the thing that struck me first, Professor Sir Andrew Pollard, was tell me, how do you become so passionate about vaccination and immunisation? Because this has really been a life's work for you.
Well, thanks very much for that. You can just call me Andy if you like, rather than have the lengthy title. I guess I really the starting point is as a paediatrician, and we all see many children with infectious diseases. And as a medical student, I spent some time in West Africa on my elective, and you realise that the real burden of serious infectious diseases in the first few years of life, and particularly in the most resource-poor parts of the world. And so really my passion was about thinking how I could work in those settings as a paediatrician. I did some research in West Africa on infectious diseases as a student, and did an undergraduate degree in immunology at Guy's Hospital. And that really was such an exciting time. The T-cell receptor had only just been discovered. And so immunology felt like it was going through a rebirth, having been largely about understanding antibodies before then. And so moving into clinical practice as a junior doctor, I was really thinking about how to build on that interest in the immune system. And so my focus was really on how can you understand immunity, particularly in early childhood, where people hadn't been doing any studies because it's so difficult to do that on small volumes of blood, and the techniques available weren't very good at that time for working with small volumes. And I thought we had something unique to do to try and explore immune responses to diseases and infectious diseases in young children. And it struck me that actually vaccines were quite a good tool to be able to stimulate the immune system and then try and understand the development of immune responses from birth through the first few years of life. And so that's really when I came to Oxford nearly a quarter of a century ago that I was really thinking about it was all about the immune system and an intellectual curiosity about the development of immunity. And I guess it pretty rapidly dawned on me that vaccines actually are pretty good as well at stopping the diseases that I've been looking after children who had them in the hospital. And so I really have, over most of the last 25 years, been much more focused on using that knowledge of the immune system to improve immunisation, improve child health by preventing disease, which has been incredibly exciting.
And there's one word in that really stands out to me, because I think we're so bad at preventing disease. We're so reactionary. We never think about what we can do before. So that focus on prevention is so important.
I agree completely. And last year, I launched the Academy of Health Sciences report on child health, which is really about the future of population health. And really they're showing that what happens to the child in the first 5 years of life. And that is true of exposure to infectious diseases. It's true of the built environment of pollution. All of those factors are really setting up the child's health for the future, whether or not they're going to be an adult who's obese with diabetes or with lung disease from a smoky environment or environmental pollution. The economic deprivation in early childhood that affects so much of life chances, and changing that environment, a lot of which is not about health solutions, but changing that environment in the first 5 years of life has been shown through childhood to reduce the number of hospitalizations, improve exam results at the end of school, and some wonderful experiments in America showing reductions also even in crime in inner cities by nurturing better in the first 5 years of life. And it's just that really prevention is really where we should be spending more of our efforts in the years ahead to change not just child health, but the future of health for the NHS.
Oh dear, my only problem is you seem to have given us enough topics to go through at least 2 more podcasts. But yes, I agree. Andy, what do you think are the big issues in paediatric vaccination and the schedule in the UK today?
Well, I think just taking first of all, a helicopter view about the future, I think one of the problems that we have both in the UK and in fact globally is technology is advancing very rapidly, which means that we can do more. But we've actually now got very few opportunities to, and indeed limbs, to stick more needles in. And I think that it's much more of a problem in the developing world where there are still major burden of infectious diseases that we don't have here, where new vaccines have to be introduced if we're going to have a big impact. Let's take malaria, for example. That's extra visits for the child in some of the most resource-limited settings and a bigger needle burden. But there are other vaccines that need to be added as well into those programs because they have such a threat of infections. And so that actually just adding more to the schedule without working out how to make new combinations is a real challenge for the future.
So that's really interesting. So, in fact, what you're talking about is how to be more efficient and effective and get more vaccines in, but continue to have the same number of visits and as few actual physical jabs as you can.
Absolutely. I think that is really what I'm sure the infant wants, but it's very much what parents want, and the vaccinators would like not to have to stick so many doses in. We are, you did ask specifically about the UK, we are about in the next 12 months to have a major change to the immunisation schedule for early childhood. The result of one of the vaccines that we have had in our program, the Hib and Men-C vaccine, which was given at 12 months of age, that is no longer being produced by the vaccine company. And so we've had to rejig the program as a result of that. And there'll be lots of communications in the next 12 months about that. And we'll be changing the schedule. And I think we'll almost certainly have better coverage as a result and without any loss of protection in the population.
I've seen a lot more bacterial infections this year, more empyemas, serious invasive bacterial infections, and that's come on the back of these huge flu pandemics, COVID pandemics. So it just underlines the importance of what we're already doing and doing that well without any gaps.
I think that's absolutely right. So that when you look at the problem with vaccination rates that we see, certainly the narrative that's in the media and from politicians is largely that this is the anti-vaccine problem. But the reality is that it is much more about access, and that this has been studied over the last 25 years. And we know very clearly that the main way that you can change vaccination rates is making it easier for parents to access immunisation services. And I think that's harder than it used to be. And it doesn't help if people are a little bit hesitant, which of course is a rational behavior. If someone's coming at your baby with a needle, it's rational to want to ask questions. But if you can't access the trusted health professional to ask those questions, then the vaccination may well not happen. So there's the whole system around immunisation needs to have improved access. Some of that is probably just making more appointments available. Some of it is around understanding the particular needs of individual communities. There's just as one example that there's one community that we're aware of in London who weren't coming forwards for vaccination because they believed you had to pay for them and they couldn't afford it. Perhaps another example is if, large family size, some communities have very large family size. And in those groups, then trying to get to the vaccine clinic with 5 children when the new baby comes is extremely difficult. I certainly couldn't manage 5 children and a new baby on a bus.
Yes, I absolutely agree. I think that vaccine access and vaccine availability is a huge issue. And I think that the recent flu vaccine and the rollout in school, where there weren't necessarily enough doses and they didn't have chance to do a second round, is an example. I think it's really important in the current cost of living climate crisis to think about how difficult it is to get to places. So when money is short, if you can't afford to feed your family, then that extra bus fare, the extra time it takes becomes much more challenging. Christo.
You touched upon issues with production of vaccines, particularly with Hib and Menc, and I wondered, was there anything that we learned from the kind of mass rollout of things like COVID vaccination in 2021 that could be used to try and circumvent some of these issues? Or do you think that this is going to be something that recurs where certain vaccines become harder to get, and so we are constantly having to shift the schedule to try and make sure there's adequate coverage?
Well, I hope that won't be the case. I think market forces really determine which of the licensed vaccines remain available. And so for many of the newer vaccines, countries do pay quite a lot for them. So the market forces are likely to keep them available. I think one of the problems with the older vaccines, the ones really which have been around for the most of the last 60 years since we had vaccination programs, are ones that we hardly pay anything for. And so there's much less incentive for some vaccines for companies to keep producing them. And something like the Hib-Menc vaccine, we were one of the few countries that still had it in our program. And so we're a large market, but not as large as you need in order to sustain a whole manufacturing facility. At least that's my guess as to why that happened.
Andy, I'm just going to take you back to something. You talked about vaccine hesitancy, and you said that part of the problem is that families just need the opportunity and the time to ask their questions, and it's a natural thing. What tips would you give paediatricians who are faced with parents who have worries, concerns, doubts about vaccines?
Well, I think it's very important that the paediatricians are knowledgeable about vaccines and how they develop their safety record, because many of the questions are actually very easily dealt with just by some knowledge. And it's quite interesting. I'm sure if you were to look in the clerkings that your junior team do, they very often don't even ask about vaccines in their clerking, and they may well, even if they've documented unvaccinated, have no plan in place for a discussion with the family, or even perhaps to offer the doses in hospital. Given how important these vaccines are, they're life-saving, that we really should have it much more in the forefront of our minds to be engaged in that conversation. And I think one of the things you find is if you have the conversations frequently with parents, you start to know what their concerns are, and you do have the answers, because that helps you make sure that you maintain your knowledge and you look up the information so that you're ready for the sorts of questions that do come up. I think there's a fundamental issue here, which goes back to other types of major public health interventions. And I think of two of the major ones in my lifetime: seatbelts in cars and then the smoking ban, both of which had huge pressure against them when they came in. But for both of those now, if you're in a restaurant and someone lights a cigarette next to you, you're not going to be very happy about that, and they would almost certainly be told by everyone around them to stop. Similarly, if someone gets into your car and they don't put a seatbelt on, you won't drive off. And in fact, even if you said nothing, the car will start beeping at you. And we're not in a situation where our society says, actually, I'm not very happy about you not being vaccinated. And we're quite comfortable with the idea that it's acceptable for people to be unvaccinated. If you reach a point where the majority of the population actually feel this is critical for the protection of their own child, but also to other people's children, that we have high immunisation rates. If there's such confidence in that, then we'd have a very different relationship with vaccination.
So, yeah, I think that's really true. Paediatricians need to be knowledgeable. They need to know about safety data. They need to listen to parents and have time to make these conversations. And I think that point you made, which is really interesting, that children who are at higher risk, so children with immunodeficiencies or parents of premature babies, actually could be the champions of vaccines because it's so much more important for their children that everybody around them is vaccinated.
Absolutely, I fully agree. And I can think of many cases over the years where a child has been severely ill or ended up dying, or even with neurological damage as a result of infection that was vaccine preventable. And for those parents, this is the most awful scenario to be in, where they've decided not to vaccinate, and then their child has had very significant injury or illness as a result.
You've mentioned some strategies for trying to deal with kind of concerns or hesitancy at an individual level. And I just wondered, with your JCVI hat on, what sorts of things, what strategies work for trying to improve vaccine literacy for the global population?
It's a very good question. It's not actually part of JCVI's remit to deal with that. We're much more on the science of vaccines and looking at the burden of disease and which ones should be used. But this whole area of what we need to do as a society to change literacy, I think there's some quite interesting research, particularly from psychologists, that if, as a parent, you turn up in the clinic for immunisation, and you haven't decided at that already that it's the right thing to do, when the practice nurse comes at your baby with a needle, the point then is usually the wrong decision is made. So we need to be in a situation where people, by the time they're having children, already are confident about the importance of immunisation. And to my mind, you only do that by starting much earlier on in life, and probably as part of the curriculum in schools. And that isn't there. I mean, it's very difficult to change someone's mind. And as an adult, we all get very fixed views on what our belief systems are. So really, if we're going to change the way society thinks, we have to start much earlier. There's also understanding at the grassroots in some communities what their particular concerns are. Some of that is a social media side of things. Some of it is informal networks that people have in their particular religious or ethnic communities, where you really need to have champions there to provide safe communication.
You've talked about what the current schedule is like. You've talked about access and availability, and we've touched on hesitancy and how to deal with that. What's new? What's round the corner for vaccines?
Well, I think for the UK, we've just turned one really important corner, which is the start of RSV vaccination, which is both maternal vaccine and also for the elderly. And I'm really excited over the next few months that we're going to see the first data on how well those programs have performed. I think we'll have the best data set from the elderly because there was a large program which was rolled out before the season. Maternal vaccination, it may be that we have some preliminary data, but it's next year where we'll have the best data, where there'll be many more mothers who are vaccinated before their babies are born, which is obviously critical for the success of the program. So I think this is a really exciting turning point. And for all paediatricians, we just know how the wards are filled up with babies with bronchiolitis every winter. The total number in the UK is about 25 to 30,000 babies admitted mostly over a 6-week period, which is why we're bulging at the edges during that period in the late autumn. And if that can be overcome in the way that the vaccines have promised to, paediatrics is transformed.
Yeah, absolutely good point. Unfortunately, we have Simon Drysdale with a whole podcast on nothing but RSV vaccination.
So just to add to that about what's coming next, there are some really exciting potential developments. The leading cause of neonatal meningitis is Group B streptococcus, which paediatricians will be very familiar with. There is now a vaccine which covers Group B streptococci, which is in development. And really now the data are coming in for that. It's largely a regulatory decision about what amount of data gives them confidence the vaccine will be protective. We know it's safe, but it's just the extent to which it will be protective. And that could come within the next year or two. And then maybe JCVI will advise that that's used in the future. And if you look across infectious diseases that have a lot of severe illness, deaths, admissions to hospital, then once you've got RSV under control and you've got Group B streptococcus under control, there's actually not very many that either have that severe disease in reasonable numbers or huge numbers of cases like RSV that is left. And you get into the point where you're starting to think, well, maybe we could tweak, say, an RSV vaccine a little bit to add human metapneumovirus or parainfluenza 3. Those on their own almost certainly couldn't be introduced because they wouldn't be cost effective for the NHS. But if you add them to existing products, for the companies, it will make them more competitive, but it would actually add a little bit more protection to our childhood programs. So I think that's the sort of direction of travel I would like to see, is that we can do better than we are at the moment. But RSV and Group B strep have really been, for me, the top of the list of the ones I'd, for the last 10 years, wanted to see happen. And I feel like we're on the cusp for Group B strep. We're already there for RSV.
Yeah, I think I love that idea of piggybacking vaccines on another, so RSV, and including new things like human metapneumovirus, which we know is causing a huge problem in Australia for their current season. Group B strep. So that's really exciting. And I think, Christo, you're currently working in a neonatal unit, so maybe you want to just touch on the huge amount of work that Group B strep causes to all these just born babies.
Thanks, Emma, because I think we see Group B strep a lot and worry about it a lot as paediatricians, but really it's the obstetrics team and midwives that have a huge role in trying to pick up mothers at risk and which families should be offered intrapartum prophylaxis and so on. In terms of where the Group B strep vaccine might fit, is this envisaged to be a maternal vaccine in the same way that RSV is, or is it a vaccine given to an infant?
So the vaccine that's being developed is a maternal vaccine that would not only, I hope, protect the infant from early onset Group B strep, but also late onset disease, and perhaps also mean that we can rethink all of those antibiotics that are being given in late pregnancy and on the postnatal wards to babies at risk. So I think it's a hugely impactful and important vaccine to have in our program.
Yeah, and I think that's such a big thing. I think we need to be thinking about our use of antibiotics. And in this instance, when we worry about group B strep, sepsis, and infections in little babies, we use a huge amount of antibiotics prophylactically. So the children aren't even unwell, and we're giving them 48 hours of antibiotics just on the off chance. So this is an enormous opportunity to save and to improve our antimicrobial stewardship.
Antibiotic resistance is a major problem in our hospitals, and I'm sure you're facing that in your centre just as we are here in Oxford. And one of the great things about vaccines is that they can be directed against resistant bacteria. And we have pneumococcal vaccines, which reduce the resistant pneumococcal bacteria that cause infections. But perhaps even more importantly, the vaccines against viruses like RSV and influenza reduce the number of inappropriate antibiotic prescriptions, because it's obviously very hard in the community to decide whether you're dealing with a virus or a bacterial infection, and so many prescriptions happen that probably weren't needed. So if you can reduce the viral infections, that may have at least as big, if not a bigger, impact on antimicrobial resistance and certainly antibiotic use.
So we can add antimicrobial champion to the rest of your titles as well.
It would be nice if you did add that to my title, but I think the most important thing here is that we don't capture very good data on the way that vaccines can prevent antibiotic use. And the reason why that's important, obviously, there's a importance for the message, but when we're calculating whether we can afford to pay for vaccines using Treasury rules, one of the key things is cost effectiveness. And if you can reduce antibiotic usage and antimicrobial resistance and its costs, then that makes vaccines even more attractive to use.
So you were saying if we treat RSV and group B strep, there won't be many illnesses left. But one of the common illnesses I see a lot of, and the effects afterwards, is chickenpox or varicella. And so for many years, we've been thinking about varicella vaccine, and we know that actually Australia, America, other countries have it. So what's happening there?
Well, that's a really good question, and it's been something at the forefront of my mind over the last 12 years of chair of JCVI, because as a paediatrician, in fact, for all the paediatricians on the panel, exactly as you say, the burden of complications of varicella is enormous. Apart from obviously it's an unpleasant childhood illness, but also the complications we all see, particularly associated with Group A strep, secondary bacterial infection. And the thing that really held things up was a a, a view which was based on some evidence that if you vaccinate against chickenpox, that there will be less natural boosting of adults, so that over the course of the next 80 years or so, we'd have a big increase in zoster in the elderly. And you might say, well, we're paediatricians, why should we care about that? And the reason is that the NHS would care because a lot of money is spent on treating post-herpetic neuralgia in the elderly, a huge amount. And so if vaccinating children did push up zoster rates, then actually the cost effectiveness becomes a problem. It's no longer cost effective and wouldn't make sense for taxpayers to pay for that. So there's been the last 12 years discussions, review of data, and finally the latest updates from the US, where they have 25 years of data to show that with all of that time, you don't see an increase in zoster in the elderly. And so I think we're now confident that introducing the chickenpox vaccine will protect children, will reduce the complications, and we don't think will have any significant effect on zoster in older adults and therefore cost to the NHS. And so part of the changes to the vaccine schedule, which are going to come in the next 12 months or so, will include the addition of varicella vaccine. And I think for all of us who have been on the front end, particularly as an infectious disease paediatrician of seeing these cases, I'm really delighted that we've managed to get that finally over the line.
Yeah, absolutely. Cause for celebration. We've been waiting a long time. So that's really interesting to hear that the Joint Committee of Vaccination and Immunisation, so JCVI, has finally got the data from 25 years of the experience in the United States of using varicella, that there is no increase in herpetic neuralgia in elderly population, and therefore it is not only effective, but financially effective and efficient, and that it will become part of our new vaccination schedule. As we touched on, the severe bacterial infections, cellulitis, meningitis, group A strep, that all occur after chickenpox are a huge burden to not only families, but the health system.
Yes,
Perfect. I think that covers
absolutely.
that.
Absolutely. I should just make one comment, which is that we have in all Western countries seen an increase in zoster in the elderly over many decades now. So there is an increase, but what is clear is vaccinating children is not accelerating that increase. The causes of it are to some extent unknown.
Maybe we should start boosting adults then.
Well, we are doing, because that's what the zoster vaccine program is, that now happens for older adults. So we have since 2013, there's been a zoster program, and it's been switched to a new vaccine called Shingrix in the last couple of years, which is very exciting.
And finally, going back to something that you talked about, I think your initial point when we talked about vaccine hesitancy is that when parents see a nurse coming towards their child and their baby with a needle, they instinctively sort of recoil. They don't want their child hurt. So, is there any work on new delivery systems or delivering vaccines without needles?
Well, there's been quite a lot of work over very many years, and there are various systems, including patches and so on. I think one of the difficulties there is none of those new technologies has really got into the mainstream so far. I mean, there are some which are being used for medicines, but in vaccination, they've not got over the line to this at this point. Part of that is just that we have a very successful vaccine program, and if you're a producer of those vaccines, to go to a different delivery system actually means relicensing, and there's quite a big opportunity cost for the pharmaceutical companies, so they're not so keen to make those changes. But I do find it slightly puzzling that no one has innovated with new vaccines to add those into these very, very crowded schedules. So I think there's still work to do, but there's lots of people working in this space. So maybe in the future we will just have slap the patch on, and that will be the answer. I think the second thing to say on this is that there's some really exciting developments about delayed release. So maybe with one needle, you might be able to start the immune response, and then rather than giving a booster, there's a delayed release of the materials so that you get a booster that happens from the original injection, but is delayed by a few months or 6 months or something like that. So those sorts of innovations, I think, are going to be game-changing to help us with the crowded schedule and perhaps increase acceptability of vaccination.
That's really interesting. And I just wondered, we know that the nasal route is effective for certainly influenza vaccination. And I wondered, is there any work looking at kind of mucosal immunity and whether any other pathogens could be targeted by what seems like a much more tolerable way of administering vaccine?
Yeah, I mean, I think the nasal route for flu vaccines has been terrific for the childhood program. It's not as scary as a needle, and you can do large numbers very quickly. So it's an extremely efficient way of approaching that. Uh, for something like RSV, there's been quite a bit of work on giving intranasal vaccine, live attenuated vaccines over quite some decades now. And I think the problem there has been either that they were so attenuated that they didn't protect, so very safe but didn't provide protection, or they were protective but not attenuated enough so that they actually cause some fever and snuffly noses. And so this is, I think that it's not straightforward to just say, let's just make a vaccine and give it by that route. The second thing I would say is that we really have a poor understanding still of the mucosal immune system. And even with the flu story, where we know that from a delivery point of view, that live attenuated vaccine is great, there isn't particularly good evidence that it's better than a needle. I mean, obviously it's from a delivery point of view, but in terms of protection, there are great studies showing that vaccinating large cohorts of children in counties in the US or in a Japanese experiment from the 1960s, that the needle works just as well in reducing flu in children, but also importantly, the transmission to older adults.
So thank you, Andy. And I think in all cases, we like to think about global health of children, not just the children in the UK. So what kind of vaccine advances are available globally? Because sometimes it's money and availability that holds things back. So what have you got to tell us about the global situation?
Well, there is definitely a lot of work going on globally, and the World Health Organization has been tracking development of new vaccines that could be rolled out to try and improve health in low-income settings. And I've been working in South Asia for the last 20 years, both in the epidemiology of infectious diseases in early childhood, and also on trying to promote vaccines and testing of vaccines in those settings and supporting governments introducing them. And perhaps for me, over the last 10 years or so, the most exciting has been around typhoid, where we first of all showed that a typhoid vaccine was protective using a human challenge model. So this is where in Oxford we deliberately infected people with typhoid by getting them to drink Salmonella typhi as if they were drinking contaminated water in South Asia. And we're able to show that those who were vaccinated had good protection. And that then supported the WHO decision to start rolling out the vaccine. And over the last 3 years, 60 million doses have been given to children in South Asia and in Africa. And in the meantime, we've been doing studies to look at the effect in children in the real world, vaccinating 100,000 children since 2017, and then monitoring them. There was a randomized trial, so some had a control vaccine, and we're able to show that 80% of typhoid was prevented in that huge clinical trial. So, I think that's been a real major part of what I've been doing over quite a few years now, and really exciting to see something we've worked on now being rolled out. And this next year, Bangladesh will roll out, and so the numbers of children protected against this disease will be absolutely enormous, incredibly important, because this illness disrupts education, causes febrile illnesses. Many people, and a proportion are hospitalized, with millions of cases every year, and at least 100,000 children succumbing to the infection.
Yeah, that's really exciting news to know that there is a vaccine for typhoid and such a huge burden of disease in the global population. But that obviously leads me to ask you, what happened to malaria and a malaria vaccine?
Well, there are now 2 malaria vaccines that are produced and are being rolled out in Africa. One is from GSK, and one was developed by Oxford and is now manufactured by Serum Institute of India. And both of those vaccines are being deployed, and we hope over the next few years to see big reductions in the malaria burden, obviously added to by the use of bed nets and the various insecticides that reduce the risk of transmission, plus intermittent treatment. So there's lots of tools now that can start to improve protection in populations. A new generation of malaria vaccines are being worked on as well, so we might have even better protection in the future.
So I think from what you say, the future looks bright. We've talked about new vaccines in the UK. We've talked about the RSV vaccine, Group B strep vaccine that may be coming. We've talked about how the schedule is going to be rejigged and possibly a reduction in the number of visits and the number of needles that each child gets. and globally looking at typhoid and malaria. So it's an incredible body of work, and it's been fascinating talking to you today. So thank you very much, Andy. We always ask anybody who comes on our podcast, they can have 3 top tips. It's like Desert Island, 3 top tips you'd like to pass on. So what are your 3 top tips?
Well, I think my top tips are get vaccinated. There's only one. And get vaccinated.
And get your child vaccinated.
Yeah, get vaccinated and make sure that all of your patients are vaccinated as well.
Absolutely fantastic. It's been a pleasure.
Thank you so
very
much.
much for having me on the podcast.
This podcast is produced by Odland Education. The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other groups or individual. You can find a wealth of information on the important work of the Royal College of Paediatrics and Child Health on rcpch.ac.uk or #ChoosePaediatrics.